Hi, everybody. Welcome to NP's Changing Practice. I'm Dr. Carol Berger, and today we are honored to have as a guest Dr. Christopher Hemmer. Chris, you've been an NP for quite a while now. His last 21 years as an orthopedic specialist, and he is a partner in Piper Spine Care. Right? Did I say that right?
Correct.
Yeah. Okay. So tell us, Chris, tell us about your journey as an NP and how you wound up in orthopedics.
Sure. But first, I'd like to thank the Nurse Practitioners Changing Practice for allowing me the forum and inviting me to speak tonight. I'm honored. I know there's a lot of big shoes that have been here before me, so I'll do my best to hold up that high level of expectation. My journey started many moons ago, probably before some of the audience was even born. I graduated from Southeast Missouri State University in Cape Girardeau, Missouri, with my bachelor's in 1995. Back then, really wasn't sure what I was going to do when I grow up. I moved back to St. Louis area. I started working in corrections medicine, which was primarily because it paid well. And that was about it. I was trying to make a little money and that off. Quickly figured out, hey, this is not a good long-term program. Applied and was accepted to University of Missouri St. Louis NP program. At the time, you basically were one of two things. You were either an adult NP or you were a peds NP. They didn't have all these subspecialties. They didn't have family. They didn't have all this subset of NPs that we have today. I graduated in 1999 as an adult nurse practitioner. I did a year of primary care at Barnes St. Peter's in the internal medicine group, which was a great learning experience.
Yeah. Was that as a hospitalist?
No, there was no such thing as hospitalists at that time.
They weren't, you're right. That was a whole new thing.
Before that, yeah, it was around, I would have said late, 2002, 3 maybe.
Yeah, you're right. Because I came in just as that was happening.
Yeah, it was definitely before the age of the hospitalist. I was brought into an internal medicine program where I had rotated through as a student, worked there for a little over a year. During that time, I ended up moonlighting in the emergency department, enjoyed it, and started kind of gravitating to all these bone things. It was like, this is kind of fun, straightening out a finger or reducing the fracture. And, it's kind of like, this is all right.
Joint injections.
Right, exactly. Right. So over time, I got to know a lot of the orthopedic guys because it was a relatively smaller hospital. Again, we're going back 20 years ago. Yeah. As I got to know those guys, I got more and more intrigued with what they were doing. And a couple of times hey, can I go down to the OR with you if my shift's ending? And I'd go down to the OR and watch them fix a hip or do a closed reduction that we were unable to do in the emergency department. And so I got to know those guys. And within about a year, they were looking to expand, and they'd never had an NP. They had 4 MDs. They had no idea what I could or couldn't do.
That was a problem back then. They really didn't know what we could do. I mean, what's our scope of practice?
Right, yeah. Exactly. It was just very cloudy. So one thing led to another. They offered me a position, and I accepted and was excited. And I basically did kind of a mini fellowship in orthopedics, specifically spine and some general ortho, but a lot of spine. And I've been working with the same orthopedic surgeon the whole time and orthopedic spine now, going on 21 years, as you said. And as I was doing that and getting more and more comfortable, I started doing a little bit of teaching, and one thing led to another. I thought, if I'm going to do all this, maybe I ought to get a doctorate. So
that's when you and I met.
That's when we
were both in the same. I think we were the second cohort.
Yeah, it was definitely one of the early ones.
First or the second. I want to say there was one before us. We were either the first or the second. I think you're right.
Yeah, it was definitely within the first 1 or 2.
Yeah, so they were experimenting with us. They didn't know what we were doing.
Oh, yeah. So, and then so I obtained my DNP, my doctorate of nursing practice from University of Missouri St. Louis in 2012. I did my doctoral work on identification and management of compression fractures. And it went well, and I ended up doing a lot of it out here in the area because I already knew a lot of the folks out here.
Right.
I've been working for so long. So,
And you teach now at St. Louis University.
yeah,
You are an associate professor.
I actually just got a tenured assistant professorship,
Yeah.
like as in 3 days ago. So yay.
Yeah, I'm due next year. I have to do the big 10-year portfolio. So
It's a lot of work.
you know what I'm doing right now.
Yeah, exactly. Right.
Writing
Yeah.
papers, getting published.
Publish and write.
That,
Exactly.
right?
Publish or perish. It's kind of
I know, and they say that isn't true, but it's true.
yeah.
You know.
So so now my kid can go to school. So that's a good start.
So one of the things now, because we're both practicing NPs. We
Yes.
don't just teach, we practice.
Yes.
And I think you practice more than I do.
We all practice.
I still practice. But when I was full-time in primary care, you were my go-to person. You were the person that if I had somebody that came in with a back problem, spinal problem, I remember sending you this one guy who had pain in his deltoid.
Mhm.
And I had seen him in urgent care, and then I had him come to me in primary care, and he right there it hurt. Within a week, it had gone to this first part of the fingers, and we had done a CT on him. And you actually got into it with the radiologist because you were sure he had a herniated disc, and they had just not shot down far enough.
Mm-hmm. Yeah, it's it's amazing, like especially in subspecialty. You really start getting into out in the weeds sometimes,
Yeah.
your own CTs, MRIs, and things like that. The people in pulmonology can read PFTs better than I can spell it. So
Right.
I think it all kind of that lay of the land and what you do every day and getting good at it.
Well, and you knew that they needed to go down just a little bit farther. And I think you found a huge herniation at C6 and 7, and you go, Carol, we can fix that.
Yeah.
And that was one of the things that you were able to identify. And my daughter, you took care of her. So, I mean, so tell us, as a primary care person, I think probably one of your biggest frustrations is we either wait too long to send somebody to you, or because we didn't recognize something, or we send you something that is way too early that we should have done a workup on before we even involved you. So can you give us some tips, some tricks on what would you look for in primary care that you could manage, when to send somebody? Explain a little bit about contrast, not using contrast, because in the ortho world, that's completely foreign to a lot of people.
And that's exactly right. When I've found, and I'm sure you have, especially seeing new grads and teaching, one of the big fears is orthopedics. And it's kind of funny to me because, we cut these kids loose with script pads and they take care of diabetes, high blood pressure, cancer, et cetera, et cetera. It's a dumb bone that people are worried about. It's like, us bone guys are not very smart. Trust me. We just make things straight. That's about
you fix it, right?
Right. We got a lot of power tools and cool gizmos, but I get more scared when I hear about using all these methotrexate and digoxin and all these scary medicines. I'm like, what if I hurt them? But no, all kidding aside, when we talk about orthopedics, I mean, there's always that bare bones the bare bones ideas behind, hey, if it's swollen, was there a mechanism of trauma, getting a plain view x-ray, something broken or not broken, and kind of figuring out what is urgent, what's not emergent. And a lot of orthopedic things can be treated very, very conservatively if just given enough time. And most of our patients are in the microwave society. They want it fixed yesterday. I've been dealing with this for 2 days. I need it fixed today. And, it just doesn't happen. But, a lot of times if we just treat it conservatively, whether it be some anti-inflammatory, ice, activity modification, things like that, those patients will do okay. But you're right. I mean, sometimes you run into things that are a lot more concerning. And in my world, especially in spine, that tends to be a big thing where everybody's worried about things like cauda-equina syndrome. Everybody knows to ask about bladder control. And the reality is, I think I've seen maybe 4 cauda-equina syndromes in 20 years. Is it scary? Is all get out when I find it? Yeah, I don't like it. But it's not one of those things that you're going to run across every day.
Right.
There's a lot of things that we talk about as far as red flags, like night sweats, fever, chills as it relates to the back. Those things get us concerned. recent infection like urosepsis, big red flag. Hey, somebody was uroseptic 2 or 3 weeks ago and they got a lot of back pain. We better be thinking about discitis, osteomyelitis,
Yeah.
bad things that can happen. Significant progressive weakness with radiculopathy, where on clinical exam, you check one side and that side is good and strong, the healthy side. And then you check the contralateral side or the symptomatic side, and that patient has profound weakness in an isolated motor group. That's a problem. We get worried about that. People that are IVDA, IV drug abuse, you start worrying about osteomyelitis again, discitis, clavicular osteomyelitis. Immunocompromised patients, that's where knowing what a lot of these meds do. Hey, not everybody walks in and says, oh, I'm HIV positive, but maybe they're on meds or maybe they had a splenectomy. And we don't
or RA, they can have rheumatoid arthritis.
RA is huge. RA is a huge one because all the immunosuppressant meds. History of cancer, and in spine, we think about primarily thyroid and, let me think of these. Hold on, I got them in my head. We think about the lymphoma, thyroid, breast, lung, renal, and prostate. Myeloma is another one we see quite a bit. I found probably, I don't know, a couple dozen myeloma cases on accident. I actually had a guy today. It's very interesting you bring that up. I had a guy today that came in from Florida. He was seen in the urgent care, had back pain, got an x-ray, and he had a lytic lesion at L1, and in all probability, he has myeloma. But, here's a case where some people would argue, well, don't get the x-ray right away. Well, and I'm not.
And you got to follow your gut too. And that's what I try to tell students. I said, you do have all these guidelines, and to get an x-ray for the back right off the bat is overused for sure. But there are times when you say, I need an x-ray. Compression fracture is another one.
Compression fracture is huge. Yeah, because again, you look at that case, if you got the 25-year-old who says, hey, I was out cutting wood all day and they got musculoskeletal pain, and that's a waste of time.
Yeah, but the first compression fracture I had was an older guy. And he had a really bad cough. But what keyed me in is he was walking. When he went to cough, it made him completely stop because the back pain was so severe. That's where I went, whoa.
And asking the right questions. People with compression fractures are better when they're recumbent. They're a lot worse with positional changes. As you said, if you watch them get up and move and they get that ice pick in the back pain where it winces and catches them, it's like, whoa, wait a minute, what's going on here? Those are kind of things, because all too often, a lot of providers want to tell an older patient, well, it's just osteoarthritis. You're just getting old. In reality is that patient was fine up until 5 days ago when they bent over to pick up the dog, or they bent over to
something happened,
and now all of a sudden they got back pain. Well, that's not arthritis, not in 3 days or 5 days. So a good history, which I know you preach on, and as do I. I mean, these are huge things. Patients with chronic steroid use, back to your RA patient, autoimmune patients,
that makes their bones
much higher risk. So
that does. That makes their bones very weak.
Absolutely.
And then when we put people on steroids, we forget these little old people. I just love it. We're going to give you 60 milligrams of prednisone to a 95-year-old person for, the next 2 weeks. And we're not going to protect your stomach. I mean, I just go, oh my gosh, they've got and they're on Plavix and aspirin. And you think their stomach is 1 millimeter in thickness, and the steroids are just going to tear it up, plus the aspirin a day. And you're going to have, a bleed all of a sudden. So you have to be careful. But,
you said something I think is very, very true that gets missed a lot is watching your patient, looking at their body language, having them go from a sit to stand position or go from the chair to the exam table. How do they walk? How do they move? Are they antalgic? Are they wincing at things that they shouldn't be? You
have to look at all those nonverbals.
Absolutely. It's huge.
It's very important. And honestly, in my experience, the patient 9 times out of 10 will tell you what's wrong.
Absolutely.
They may not know what to call it, but they'll tell you by what they're saying and doing. And then if you ask the right questions,
that's the key.
You can probe just a little bit more to get that, specific area. You'll know what to look for or what to go for.
One of the things I tell a lot of my students, and I practice this every day, is, when patients come in and they start using medical words to me, I'll still ask them, show me where it hurts, because I'll have lots of patients tell me, oh, I got sciatica. And I'm like, well, which leg hurts? Oh, my leg doesn't hurt, it's my back. And it's like, so they're using words that they think
They
know what
don't
they
even
mean.
know. Yeah.
No, they don't.
Yeah. And so like, yeah, that's a good point, because I try to make my students explain pathology in everyday language.
Right.
And that's a key for me. Now, people disagree with me and
Yeah.
they'll say they need to understand all the fancy medical terms. And I'm saying, you can't explain it simply unless you understand it deeply.
Right. Yeah, you got to give them everyday analogies. In spine, I use the jelly donut.
I love I love that one. That's so cool.
Everybody knows what a jelly donut is.
Yeah, when you open that thing up,
right,
the jelly's going to get hard.
Right.
Yeah, so, I actually borrowed that from you. I teach that.
Oh, that's great. I mean, people get it. You go in and you try to show off with the $10 words, and all you're doing is confuse them, and they don't understand it. You haven't done anything to help them.
Well, and even our students, when we teach our students to explain things in very technical language, my guess is they don't understand it as well either.
Not yet.
They've just learned how to memorize text to appear like they know what they're talking about.
Right.
But they couldn't break it down and explain it like a jelly donut to a patient.
Right.
Or diabetes.
Yeah, exactly. Another big thing I would impart to those that are kind of getting started, students or new practitioners, is look at the patient, not just looking at them, how they move and how they get up and down, but physically looking at their skin. Is there atrophy? Is there muscle fasciculation? I had a patient sent to me once by another surgeon who said, oh, they got a drop foot, But when I'm looking and examining this patient, they had muscle fasciculations. It's one of the first cases of ALS I ever diagnosed. And
oh, wow.
The guy had true muscle fasciculation and he had weakness. And so, looking at those patients, I had another case where I got called to the ER for sciatica, and I examined the patient. I know her, I'm looking at her, I'm talking to her. And I always make a habit. I said, look, let me take a look at your back. And I look at her back, and there's a vesicular rash going out of her back, down into her butt, down her leg.
Got shingles.
You got shingles.
Yeah, so, it's not sciatica, it's shingles.
Exactly. And the ER doc asked me, he was kind of being a smart ass, and he said, well, what are you going to put her on, a dilaudid patch or this or that? I forget whatever he said. And I started laughing. I said, no, I think I'll use Valtrex for this.
Yeah, cyclovir might work, He
just couldn't believe it. So, it was kind of fun. I mean, and I know the guy, he was a good guy, but but again, just looking at those patients, talking to them. I had a case not too long ago in the ER, was the same thing, where a lady had back pain, had the Mayo Clinic workup somewhere else. She had shingles. Nobody ever looked at her back. So those kind of things do happen. So again, not only looking at their body language and how they move, but physically looking at their skin.
Yeah,
looking
putting
at
your hand on them actually don't stand at the doorway asking questions.
Right.
You do need that good history. You do need to ask good questions, but you bring up a great point, Chris, and that is that we need to physically get in there and look and see what they can do. Now, I love this. I mean, I'll tell them, get up on your toes, get down on your heels, do all those things, but I don't know exactly what a diminished or not being able to do, where that corresponds to necessarily the spine.
Sure. But
the one thing I do use from you all the time is the dermatome chart.
Yeah.
I pull that up when they start telling me my pain is right here and it's going to these 3 fingers.
Right.
And I'll look at my chart and I'll trace it and I'll say, oh, I think you're C6 or C7 is the problem.
Yeah.
And then I'll go and look at that CT scan or whatever, and 9 times out of 10, it'll be there.
Right. No, and it is helpful, because again, it goes back to, hey, show me where it hurts at. And I kind of jokingly say, like when I have students with me, if a patient's drawing an L5 distribution, they don't know it's L5. They just tell me where it hurts, or they're showing me where it hurts.
That's right.
Their stock goes up. But when somebody comes in and says, oh, it hurts all over here, and they're rubbing 7 different distributions, their stock goes down a little bit. So again, trying to figure out, hey, is this something I really got to be jumping on and worrying about? Or is this something maybe I get by with a little anti-inflammatory, a little steroid, or a little PT or something else? So
what do you tell your students? What's your biggest tips?
So I got a few. I wrote down some pearls. I cheated.
All right.
So a couple of them we already hammered home. Listen to your patient. Talk to them and listen to them. Don't interrupt them. Listen to them. That doesn't mean you got to listen to the lady that's 80 years old tell you about 1912. But it does mean you can redirect. Okay, I get that, but tell me about your XYZ. Look at them when you're speaking. Don't look at the damn computer in the room. Talk to the patient. Sit down like Carol and I are doing and talk in eye-to-eye contact. That speaks volumes, because one, it tells the patient they're the most important thing right now. But if I got my back to the patient and I'm pecking away at the keyboard, it tells them that I don't give a damn what's going on with them. I'm worried about what's on that keyboard.
Yeah, and that's true. I second that wholeheartedly. You've got to look at your patients and make sure they know you're interested in them.
Absolutely. If physically possible and feasibly possible, leave the cell phone out on the desk or leave it in your office. You know, there's nothing more annoying than that phone beeping and chiming and whatever while you're trying to talk to a patient. It just sends bad vibes. When you're talking to the patient, again, sit down. When I walk in the room, one of the first things I do besides shake their hand, say, hey, Chris Emmer, how you doing today? Is then I sit down and I face them and I look at them and I very candidly say, tell me your story. What's going on with your back today? And I just listen and then let them fill me in. Okay, this is what's going on. And as Carol said, they tell you the story, then it's my job or your job to ask the right questions to get the right answers to know how to put their story together into what's exactly going on or not.
And that's the pathology. That's why I always try to hammer, you can't teach pathology and expect them to understand. It seems like we teach pathology and we think if they memorized it and they can answer the questions about all the right things, that they understand the disease process. But the patient doesn't come in giving you the pathology.
No.
They tell you it hurts here.
Right.
And you have to figure out, by knowing the pathology, what questions to ask that will give you, narrow that down to what I need to be looking at. Is this, you know, like you said, back pain, is it scabies or any shingles, or is it a really sciatica, you know, I mean, and that comes, so we teach it one way, but we really apply it backwards.
Yeah, it's asking the right questions to narrow that differential down to make it as reasonable as possible, and then figuring out what
do I do from there?
Yeah, what do I do to prove or disprove it?
Yeah.
A couple other easy, cheap pearls. Be honest with your patients. You're not always going to know the answer, and I tell them that. Look, you know what? I'm not sure, but this is what we're going to do. We're going to get this test. I'm going to send you to this person, or we're going to do this to try to help narrow down what is or what isn't going on. Do what you say and say what you mean. You know, if you tell somebody, hey, I'm gonna send you this medication out, make sure it gets sent out. If you're gonna order a test, make sure that test gets ordered, because you know your word is important. And if you're not carrying out with that, then patients lose trust in you, and that's a bad day. So that's huge. I will tell you, and I will tell you guys up front, I'm terrible at this next one. Good work-life balance. I'm terrible at it. So,
we say it, but
it sounds good. It rolls off the tongue. I will tell you guys, you know, the better work-life balance you have, the happier you're at work, the happier you're at work, the happier your staff and patients are, your home life. But it's hard. It's not easy.
It's really hard because it's different than the nursing role where you clocked in at 7 and you can maybe say you might clock out at 8 because you had to work a little later. This is completely different because I mean, I just got home. I went to work at 10. I got done at 6. I still have a few charts to close. I still have some things I have to look at for labs I ordered. It just, you know, it's more of a continual.
Absolutely. Yeah. It's not a 9-to-5 gig. It's not a punch in, punch out kind of thing.
But it's also very enjoyable.
Oh, it is great.
I wouldn't do anything other, you know.
No. It's a very much a calling. It is not a job. It's it's how do I
It's
want
a
to put it?
calling.
Yeah, it is. It's a
It's a
calling.
calling.
Yeah,
It's a calling.
without
You know,
question.
you're really, if you went down and you sat down, how many hours I put into how much did I make?
Right.
You would probably make more just doing your, 12-hour job. So if that's what you're looking for,
Yeah.
this isn't the route,
Yeah,
But if
exactly.
you're looking for autonomy to a pretty large degree, you really enjoy a lot of autonomy. Dr. Piper trusts you.
Yeah.
You've got a good work relationship. That's also real important
Sure.
to
Sure.
really match. And then your job. You know it backwards and forwards. You know what you need to do and what you need to check on. And your patients love you. I'm one of them. And I absolutely can vouch. You do sit right down, you look at me and you say, Carol, where does it hurt? And then you do the tests you do, and we figure out what we're going to do from there. And you're very good at what you do.
Thank you. Thank you. One of the last parting wisdoms that I've learned over the years, and this is School of Hard Knocks, is find something that you like and then you do it. So you say, hey, I want to be an NP. Great. Do you like feet? Do you like derm? Do you like ortho? Do you like diabetes? Whatever.
Whatever it is, yeah.
And then get good at it. If there's other certifications to make you better at it, do it. Kind of find your niche and carve it out, because if you really enjoy it, you're good at it, then people are going to notice that. They're going to send you patients, and pretty soon you're going to have more work than you know what to do with.
Well, and then back to that work-life balance.
Yeah.
When you're having fun doing what you do, even though it might be heavier on the hours than you would like, it's fun. And when you do discover something, or you do fix somebody,
right,
and you get that that appreciation of how much they cared, they thank you for how you changed their life.
right.
There's no words.
Yeah, no, I can't express to you guys, and some of you may already know this because you've had it happen. When that patient comes back to you and they got a tear in their eye and they're just elated with how good they've done or what you did to help them or whatever, that's volumes. That's just volumes.
Mm-hmm.
Above and beyond the thank you cards and all that, that's nice, that's great. But man, when you get in that room and they want to, they're looking at you and they're putting their heart out, and they're telling you how much you really helped them, or how much you helped their mom or their dad or their whatever, it's huge. It's really priceless.
Huge. And there's no price tag on that. Yeah. And like I said, well, Chris, I can't thank you enough for serving our community, for being the NP you are, and you have truly, truly changed practice. You have.
Hopefully for the better.
You have, and you're impressive. Your reputation goes before you. And I hope all of you that are listening have somebody as wonderful as Chris to call when you have an ortho problem.
I really appreciate the opportunity to come and talk with you. Good luck to everyone in your future endeavors. And thank you for Nurse Practitioners Changing Practice for allowing me to sit and just kind of shoot the breeze for a while. I love it. I appreciate it.
Well, we appreciate you too. And that's the conclusion of NP's Changing Practice. Be sure and tune in to go to our website, npschangingpractice.com. You'll find games, you'll find things to help you study, resource material, lectures, all kinds of fun things. So we look forward to seeing you and talking to you next week.
Great. Thank you.